All right, everybody, hello and welcome from Cancer Care Northwest. We're on their northern campus here, and Dr. Robert Fairbanks joining us now, and he is a radiation oncologist. I got to get all of it right.
That's correct.
Okay, I got to keep my notes. We're going off his memory. We often look at Cancer Care Northwest, and there's so many different divisions and so many types of cancer that today we're talking about lung cancer. Of course, the month of November, we tend to look towards that. So thank you for joining us.
My pleasure. Thank you.
Let's do something that maybe can't be done. But what is lung cancer? Let's define it for those people watching.
Well, so it's cancer that arises in the lung.
Okay.
What is cancer? Cancer actually, the way I like to think about cancer is that there are two features. One is the uncontrolled growth of cells. So our normal cells have the ability to stop growing.
They grow as needed,
right,
in a controlled,
correct,
corrective state.
And then, but malignant cells have lost their ability to inhibit growth, so they just grow without control.
Right.
So that's one feature that makes something cancer. The second feature is that those cells then can spread to another part of the body. And that's really what makes cancer life-threatening, is the ability to spread to another part of the body. And usually the way that it spreads is through lymphatic channels or through blood vessels, or just directly invading into things that are around them. So lung cancer is a group of cells that have lost their ability to stop growing, that arise within the lung, that can spread to other parts of the body and cause life-threatening problems.
So once again, when we talk about cancer, we know that early detection is by far going to have the most successful outcome.
Correct.
When it comes to whatever type of treatment it is, no matter where that cancer is.
That is correct.
Okay. When we look at lung cancer, we then question, lately we've been talking about genetics. That's been a big thing, and we have a lot of genetically linked diseases that are out there.
Right.
Is lung cancer part of that chain?
Lung cancer is, for probably decades we've realized that there is some sort of a connection between genetics and the susceptibility to get lung cancer. It's probably more predominantly about exposures, but there is a genetic component to it.
So let's go to that end then with the exposures, environmental exposures, and also the exposure in which we have full control over.
Right. No,
smoking.
Right.
Okay.
So environmental exposures, including secondhand smoke.
Okay.
But probably the most predominant environmental exposure is radon gas. We all should have our homes tested for radon gas. That's considered to be the second leading cause of lung cancer.
And the first being?
Smoking.
Smoking. So again, this is one of those diseases that is very preventable in what we know.
That is correct.
Between the radon and the abatement of radon, and many homes have that radon abatement already.
Right.
Because they're, it's just one of those things that's in the soil. You can't get rid of it in there, but you can get it away from the house.
Right.
And then to quit smoking, or not start smoking.
Right.
And just eliminate that altogether. All right. When we're looking at then lung cancer, which is our focus.
Right.
So let's say someone's gone in and they've been treated. They've had a lung scan, or their doctor said you're in that zone where we need to make sure you're okay. What treatments are available then for lung cancer?
Well, there are several treatments that are available. Historically, surgery has been the mainstay of treatment for lung cancer, but then we realized that just treating locally, which is what surgery does,
right,
doesn't address the overall picture. We started then looking at lung cancer as being a systemic illness. And so when you look at it as a systemic illness, then you have to consider what's going on in the rest of the body and the places where it can spread. And so that then brings in chemotherapy. So chemotherapy has become part of the mainstay of the treatment of lung cancer as well. Surgery ends up being very difficult if the tumor is locally advanced. So if it's going into lymph nodes that are in the middle of the chest, then they can't get everything out with surgery.
Right.
And so that's where then radiation therapy historically came into the picture.
Back that up.
If they couldn't do surgery, then radiation therapy was the local or loco-regional, meaning the regional lymph nodes and things that are all within in the chest. Radiation therapy is used to treat loco-regionally. And as we've gone through the years, what we found is that radiation therapy by itself didn't work as well as radiation therapy and chemotherapy together. And so for people that can tolerate it, we use radiation therapy and chemotherapy for more advanced disease.
The technology, the knowledge, all of those things is exponentially growing as we go into the future. And we look at what we did in the 50s, you know, and some, you know, we used to go into a shoe store and you could put your feet underneath a radiation device and look at your toes move. That's not the case. The technology exists and it's crazy. We're going to show you a little bit of that now.
So a linear accelerator is the piece of equipment that you see behind me. It uses X-rays, which are accelerated in a way that that allows them to create high energies of radiation that will allow us to treat patients with beams of X-rays that penetrate all the way through them. In order to do that, we get electrons spinning around very quickly and then run them into a tungsten target. And X-rays are elaborated from that. And then when they're elaborated from that, what we do is we use special ways of blocking and shaping the radiation so that it comes out in a very focused way and in a very even energy. That energy then passes through the patient. And so our job is to come from several different directions with those energies of X-rays and customize a treatment that aims right at the tumor and avoids normal tissue. One of the advantages of linear accelerator is that we can use the X-rays or photons to treat when the electrons run into that tungsten target. But we can also move that tungsten target out of the way and just bend those electrons and aim them directly at the patient, and then we can use the various characteristics of either electrons or X-rays to customize the treatment for each patient. The advantage of electrons is that they're actually a particle, and so depending on the energies, they will go in to a certain depth and then not have very much radiation beyond that depth. We can control the depth that we're treating. If we're trying to treat a superficial cancer like a skin cancer, we can use electrons. If we're trying to treat a deeper cancer like a lung cancer, then in most cases we would end up using X-rays or photons that pass right through the patient and focus them coming from various directions right on the target. So here at Cancer Care Northwest we have Elekta Infinity accelerators, linear accelerators. And there's some really significant advantages. This is one of the more modern machines that exists. We have several special features. One feature that allows us to image patients in the treated position and then automatically position the patient in a very accurate way based on computer input as well as our radiation therapist, human input. We can use the technology to look inside of the patient and then automatically align to that patient's internal anatomy, and then we can reproduce that exactly every day. And the computers remember everything that we're doing from day to day. So it's a very advanced piece of equipment that helps to facilitate the human component of the accuracy of our treatment.
So the Elekta Infinity that we were looking at, this is one of the tools that is used in order to treat and try and cure cancer in somebody.
That is correct, and like we talked about in that video, we can actually now see inside of patients and calculate the way to give radiation in a very customized way and in a very specific way. Initially we started out by doing CAT scans to help us plan the radiation treatments.
And you go, oh, there, it's over there in that left lobe, and oh, it's over here, and there's maybe a mark on the chest. Going, okay, right. That's what those two spots.
But what really moved us forward is when we were able to, at the treatment machine, be able to do a cone beam CT where we scan around the patient and then we can see inside of them. And one of the things that's really cool about the new technology is that the computer can identify what's inside of the patient and can actually get the alignment very, very close just by the computer making that adjustment. And so we use both computer adjustments and really high-end technology to get things extremely accurate. And then we have the therapists that are extremely well trained in all of this, and the physicians that look at everything on a daily basis now. We look at almost every single site that is being treated to make sure that it's aligning perfectly. And the real key to what happens is not necessarily the dose of radiation that we're delivering to the tumor, but really the avoidance of normal tissue.
So again, trying to hit that tumor, and the friendly fire is minimized with the healthy cells to make sure that
Correct.
they're there to rejuvenate once that cancer is gone.
Right.
All right, so the good doctor is a fairly mellow lad, but he does get a little excited when we start talking about, and when I brought this up earlier, if you relied on the information that you had 10 years ago or 20 years ago, you would be so far off the mark. Things have changed so much. Your education has continued. I'm assuming your learning and your learning curve continues even though you're, I'll say, decades into your doctorate.
I am decades into it.
You're like, thank you.
You are correct. Thanks for pointing that out.
Yeah.
But things are very different than they were. I remember in my training program, we didn't even have CAT scans as part of our treatment planning process. Where I did my training at Johns Hopkins was one of the sites where they asked us to start doing that, and that happened during my training.
Okay.
So
So
that
we've come
has
a long
become
way.
an integral part.
Yeah.
In the types of treatment, there are types of treatments now that exist that we only dreamed of back then because the technology was so unavailable.
But some of this, you brought this up, the Saber. You got very excited about the Saber, and that's very new technology, but some of that is almost, in the world of medicine, breaking news, and the fact that only in the last 30 days are you seeing some of the results.
That is correct, yeah. Saber Technology is stereotactic ablative radiotherapy. So ablative means that we completely kill anything within that target zone. So it relies on the technology that allows us to be extremely precise with that target zone. We can't have anything normal that we don't want ablated within that area. But within just the last month, we have found that some of the newer immunotherapies and targeted therapies together with Saber treatments can double the expected survival in patients who even have metastatic disease,
Stage
as long
three,
as it's very
stage
4.
Stage 4?
We're making advancements in very early stage disease. We can use the Saber technology for people who can't have surgery. We can use Saber technology to treat a tiny little tumor in the lung and have a very high chance of cure. Back when it first came out, nobody believed it. We didn't believe that radiation could actually achieve that high of a chance of cure for those small lesions. And so for people who can't have surgery, we have that opportunity now too. So we're improving things on both ends of the spectrum. We're helping people with early stage disease, and we're also able to extend life for people who have more advanced disease as well.
Let's talk about a piece of that you'd mentioned just a couple of minutes ago, the immunotherapies that are coming along. This too is groundbreaking, and it works in conjunction with radiation. It works in conjunction with surgery, depending, where they're able to target to a genetic level some cancers, and they're adding more to that all the time, I would imagine.
Yes,
or trying
absolutely.
to.
I mean, it's taking off. It's not my area of expertise. The medical oncologist.
Oh, I know, but I love bringing you into this because
it is really exciting to see how that works in concert with everything else that we're doing. We can look at the genetic abnormalities of the cancer and try to target the cancer instead of targeting the person, and so we can see differences in the two and use targeted therapies for that. We can use immunotherapies that are targeted as well, but what they're targeted at is how cancer tries to hide from our immune system. So the cancer uses things that our body has developed to protect its own normal tissue from our immune system, and the cancer masquerades as a normal cell.
Cancer's bad stuff.
But
It's
we have
tricky.
these newer immunoagents that these immune therapies that will uncover that masquerade and let our immune system attack it.
Okay, I'm going to walk you down another path. Bear with me.
Sure.
So that's not your area of expertise. Surgery, not your area of expertise. You're the radiation dude. So now you have a patient that walks through that door, and this is something that we talked about a couple of years ago, is that when they walk through that door, they're not just getting you, they're getting this team. And this is the part that excites me, in as much as it didn't used to be this way, is that now there's this collaborative effort to really get behind the patient and say, we don't care where you work or who you are, you're going to come in on this team and help us.
That is correct. We have what we refer to as tumor boards every morning, where depending on the site, like just this morning we met in a tumor board, and it was a citywide meeting, places all around the city, all video conference in, and we review the pathology, we review the CAT scans, we review the PET scans, we have the radiologists there, and the pathologists, and the surgeons, and the medical oncologists. And these are people in all of the groups in town. It's not exclusive to Cancer Care Northwest. We're all working together to fight cancer in the region.
So if someone's doctor's at Rockwood Clinic, you're on the north side, you may very well be a part of that team and
Right.
say, all right, this is what we're able to do for you, and away you go.
Right.
That part of it gives me so much hope in the fact that now you have hundreds of years of experience.
There
Looking-
are, not just my decades, there are
Not your decades, hundreds of, but you have a lot of people with a lot of experience looking at something
Right.
and coming up with what will hopefully be a successful outcome, and the steps in order to take to get to that successful outcome.
Right. And it's good in several ways. I mean, it's good for each patient because they're individually approached by a whole team of physicians with varying perspectives on what to do and how to do it. And and people who have been like to meetings where we've learned these very new technologies can bring that to the table, and then the entire community is aware of the new things that are going on.
So everybody's learning as well as sharing what they know.
Right.
That's pretty cool. 20 years ago, there are some cancers that are just more successfully treated than others. Lung cancer was one of those that was, you're going to lose a lung. Yeah, we're going to take the lung, you're done. You have more hope now than you did 10, 20 years ago over these outcomes and these treatments. I mean, and I think the patient then has more hope.
Right, much more hope. As a matter of fact, the not just the therapies that we're coming up with, but our approach to finding cancers is leading to a higher chance of cure. So there are a few things that lead to higher chance of cure. I mean, we've got all of these better treatments. We've got this Saber Technology. We've got immune therapies. But at the same time, we have better ways of detecting cancer.
You've got to find it. Yeah.
Right, like PET-CT, for example, helped us to realize, some people have more advanced disease. And so, I'm not sure, have you heard of the Will Rogers effect?
No.
So
Do tell.
So, this sometimes offends people from California, but we're not from California, so.
If you're from California, we'd love to apologize, but I don't know what he's going to say next.
So Will Rogers made the comment that when the Okies left Oklahoma and moved to California, that it increased the IQ of both states. And so, he said it in jest.
I got you.
But the concept, when we think in terms of cancer, we refer to it as stage migration. If our test for identifying what stage actually exists is improved, then it improves things for all stages.
Right.
That is, if people who previously were in stage 3 actually had very early stage 4 disease that wasn't able to be detected, we find that they're in stage 4. Well, that improves the outcomes for people with stage 4. It actually opens the door for us using newer technology for them and improving outcomes. But it also it purifies this group as well, and so it makes them better off as well. So stage migration, early detection of cancers, better therapies. Over the past 25 years, the relative cancer mortality rate has decreased by about 25%.
Yeah, it's huge.
And that's stage for stage.
Right.
So over the years, we're seeing this major impact of all of the factors that are decreasing the likelihood that somebody will pass away because of their lung cancer.
Earlier it's caught, I'm assuming hopefully the less evasive or the shorter term type of care is available. I'm making that assumption. I don't know if that's true, but
Can you say that again?
That the care is, it's not going to be as crazy when it comes to all the radiation, all the chemo, the surgeries. If they catch it very early, then it opens up all these possibilities.
Right. Early on, you have a lobe of the lung removed,
Yeah.
very high chance of cure. If they can't have the lobe of the lung removed, we use Saber Technology, very high chance of cure.
So we have better options earlier on. Who should see? So how do you know to be seen? To be tested? Boy, look at that.
Well,
It's like, well, wait a minute. No, it's,
No. There are several different things. I mean,
Right.
one thing is anyone that has a history of smoking, or a family history of lung cancer,
right.
that's
Age
50 or older.
Okay.
Some guidelines are a little more strict, 55 and older. But if you're 50 and older and you have a history of smoking, you should talk to your primary doctor about whether or not lung cancer screening is the right thing for you.
This is the first step. And again, if any time I say anything that you don't agree with, you feel free to share it. But we need to really have that conversation with our general practitioner, our
Absolutely.
physician, and they should know everything about us, and that we should be able to then ask those questions openly and honestly. You know, some people are afraid to ask a doctor or to question a doctor, and really we need to do that for ourselves and make sure we have that relationship.
That is absolutely correct. And you know, a lot of people are afraid of having that scan and what they will see on that scan. Almost half of the people, just shy of half of the people who have lung cancer screening CT scans have little tiny abnormalities in there that are not cancer.
I had a lung screening, what, 2 years ago, right? Or last year, 1 year
Last
ago.
year.
And they were able to compare it to previous films from years ago when I was busted up. And he goes, no, we can take your previous films from whatever this neck thing was. And he said, you're fine. You know, but
That's very good to hear.
even though I felt it was going to be okay, you still have that
Anxiety.
anxiety, that
Absolutely.
angst when you go, okay, put it up, let's see what we got.
And so it does take some bravery on the part of the individual to go in and have that discussion. And then their primary care doctor is able to refer them to the right people. I know that, I think that you probably, the last time you and I met, we talked about this, and you were just right on the cusp of being able to consider doing that.
Yeah.
So I'm glad to hear that everything went well.
And
And
it's
you probably are scheduled to do it here pretty soon again, because you usually do it 3 years in a row.
Once
right?
they get hold of you, you know.
And is they we, since we're all a big community?
Yeah, we're all a big community. Everybody
We'll talk
wants-
afterwards.
Do you see how this works? Cancer Care Northwest, really, as I've been affiliated, we've discussed for years. I have been promoting the message of early detection, and that's breast cancer awareness, and that's lung cancer, and now the brain and everything that's involved with that. It's sort of a body thing. It's a whole body, and
It
you
is.
guys have a lot to cover.
Well, you talk about collaborative efforts. One of the things that really drew me to Cancer Care Northwest is the multidisciplinary approach that we have.
Right.
We have surgeons, we have medical oncologists, we have radiation oncologists, we have nutritionists, we have psychologists that can help people through things. I mean, every one of us going through this, it's a very difficult thing, even if you have a high chance of cure. And so we want to treat the whole individual.
Okay. Thank you very much.
Thank you.
I greatly appreciate it. You've got a great handshake too, by the way. Cancer Care Northwest, if you have questions, talk to your primary physician. This is absolutely, as you meet with them, and they may be running half an hour late. They may have lots of people scheduled. Once you have them in your sights, talk to them about these things and get that relationship set up so you can have these honest discussions of whether you should have this scan or that scan. You're all the better for it, and early detection is the key. I mean, that's just the bottom line.
Can I say one thing about early detection?
Sure.
Because the early detection is, the Community Cancer Fund and Inland Imaging are really a very integral part of the early detection program here in town. We tried to do a part of that, but realized this really needs to be with the radiology group.
Bigger thing.
But they're part of this whole community thing that
Right.
we're talking about, and charitable organizations like the Community Cancer Fund provide funding for stuff like that too. So
Okay, so there's no excuse, is what you're saying.
This is something that is really the whole community is behind early detection and cure of lung cancer.
Okay, on that note, we'll say goodbye. You can share this, you can rerun it, you can look at it again, but the bottom line is, again, have those conversations, know what's going on, and know that we don't have to whisper the word cancer anymore. We need to get out, shout it out, and get the scans and make sure that we're as healthy as we can be. And the nutritionist thing, that's crazy.
It is.
Yeah,
It's
all
important.
right. Have a great day.